This is April Van Buken and Nursing 136 Pharmacology. Week 6 lecture is what we're going to cover in this video, chapter 22, 28, and 29. So we'll start with the antihypertensive drugs. Antihypertensive drugs are used to treat hypertension. There are two groups of people who should be on antihypertensive drugs. So people over the age of 60 whose blood pressure is greater than 150/90. So that's one group. The second group are people who are under the age of 60, or people with diabetes, or people with chronic kidney disease. No matter what age the chronic kidney disease or diabetic patients are, if their blood pressure is greater than 140/90, they should be on antihypertensive drugs. When you're working with patients who have been prescribed antihypertensive drugs, they'll also be prescribed an exercise regimen that should always be approved by the physician. So, but definitely we want them to exercise. We want them to have their blood pressure taken regularly. We want them to take their meds regularly. We don't want them to stop abruptly and have their blood pressure skyrocket up again. And we don't want some of the side effects that come along with some of these medications. So we would tell them to take their blood pressure regularly, go to the doctor regularly, take their meds regularly without stopping. We want them to exercise and take their medicine every day. And unfortunately, people who start taking antihypertensive drugs usually have to take it for life, because it is not the majority that can change their modifiable risk factors enough to come off the meds, although many people do, but it is not the majority. So you'll tell them, you know, this isn't like the flu where you take it for a couple of weeks and then come off of it. You take it until you don't need it anymore. So I've got some slides that you've seen before. All I want you to know about this is that these drugs deal with sympathetic, which would be adrenergic, or anti-adrenergic, and parasympathetic is just on here to be on here. There aren't a lot of parasympathetic drugs that impact the heart, but there are a few. But parasympathetic is cholinergic or anticholinergic. You've seen this before. So adrenergic, which goes to the sympathetic nervous system, has beta-1 drugs. Some are going to increase and some are going to decrease. I still always like this picture because it tells you sympathetic, alpha, beta. Knowing what group is in tells you what they do. Do they vasoconstrict? Do they increase contractility in the heart muscle? Here's another picture that I like. It just gives a nice visual of all of the factors that are involved in blood pressure. Cardiac, volume factors, central nervous system. All of these, see all the drug, these are drug categories. See all the drug categories under each section? All of these kind of drugs impact the blood pressure. Do you have to memorize this? No, I just want you to see the variety, okay? You've seen this before. This one shows you, and this is a busy slide, but it shows you that the parasympathetic system is muscarinic, and it deals with these smooth cardiac glands. The sympathetic is adrenergic, and it's alpha and beta receptors in the heart, blood vessels, and skeletal muscles. That's all I wanted you to know. This is something new, and it's kind of a nice diagram, something that I understand and that I like, because it tells you agonists make things happen, right? Antagonists are going to cause the opposite effect. So a cardiac agonist is going to stimulate, right? It's going to stimulate the blood pressure, stimulate the heart rate. It's going to make things go up. So these swim lanes here, these are drug names. So all the blue is drug names. All the yellow, these are drug names. But where the arrows are show you what receptors, where they function. So dopamine is this one up here at the very top of your screen. It's an alpha-1 agonist. So this is where it works, and it's going to increase the blood pressure. Okay. Clonidine is an alpha-2 agonist. It's going to stimulate. Does that make sense? Labetalol drops the blood pressure. It's an alpha-1 antagonist. So all these drugs just kind of tells you if they're alpha-1, alpha-2, beta-1, beta-2. Don't worry about beta-3. But it's just organizes them quite nicely. I liked it and wanted to share it with you. So one category of drugs are called adrenergic drugs. So there's 4 different types of adrenergic drugs. I've got them listed on your screen. There's different, they're dual action where they do alpha-beta. There's labetalol, which I showed you on the one slide. It's a alpha-1 antagonist. And labetalol and carvedilol, they have dual effects, right? Because it's a dual action. And they vasodilate because of the alpha-1 receptor blockade, but they also reduce the heart rate because of the beta-1 receptor blockade. So they're alpha and beta. They're both very popularly used. They're very well tolerated. They're used for hypertension, heart failure. And the contraindications would be if somebody's heart rate is really low, if they're in heart failure, if they have any kind of asthma or lung issues, we would not want to give this to them. Category 2, neuron blockers. So the neuron blockers would be either centrally or peripherally located, and the examples are listed above. One example of a neuron blocker, which is also a alpha-1 blocker, is Flomax. So the peripherally acting alpha-1 blockers is a neuron blocker, but it's also in the category 4 on your screen, alpha-1 blocker. There's a med called tamsulosin, and it was originally created to dilate vessels, but it doesn't do a very good job in the heart. It dilates the vessels for patients who have benign prostatic hypertrophy. So it's not used to control blood pressure. It's solely for symptomatic BPH. And what happens when somebody has a enlarged prostate, a male patient has an enlarged prostate, they can't urinate. So the name brand is Flomax, so Flomax makes it flow, right? It dilates the vessels there and allows them to pee. So it is a hypertension drug, but it's not for the typical hypertension that we see. So they're not used for hypertension, even though they're in that category. You'll just see dual acting and the centrally acting adrenergic neuron blockers. Okay, and even the centrally acting, they're not typically prescribed because of the side effects. The side effects are pretty severe. So adrenergic drugs, there they are. It's one category of antihypertensive. Now we're going to go into some of the major categories. There's beta blockers, beta-1 blockers, beta blockers. So it's all cardiac, right? So beta blockers deal with the peripheral nervous system. They all end in LOL. See all the names, propranolol, metoprolol, atenolol. Don't worry, there's a slide with all the names on them. I know the names aren't listed here. Look at the action. They decrease the heart rate. They decrease the force of contraction. They decrease AV conduction. And I know you haven't had a lot of heart stuff. In our next lecture, I'll go over a little bit of it. But when the AV conduction decreases, it slows everything down. So they reduce the heart rate through beta-1 receptor blockade. Long-term use causes a reduction in peripheral vascular resistance, but that's okay because these drugs are great. They're used for hypertension, they're used for heart failure. They block beta-1 receptors to produce vasodilation. It decreases the SVR, and it is used so much. They're used so much. So the side effect is what we discussed in class in week 5, headache, dizziness, all the other side effects listed on the slide. And the one that's not listed is the sexual dysfunction. So that's a big reason for noncompliance, and so that's why I keep drilling it into your guys' head. We want to make sure people are taking their drugs. Also, for diabetics, beta blockers can alter blood glucose levels. So if you had a diabetic that was put on a beta blocker, you need to be careful and you need to tell them to monitor their blood glucose. But these drugs are used for hypertension. Now, another category, they're called ACE inhibitors, angiotensin converting enzymes. ACE inhibitors end in PRIL. So think of me with ACE inhibitors. They end in PRIL, like April. So angiotensin converting enzymes are used to treat hypertension and congestive heart failure. They relax the blood vessels and thus decreases the blood volume in order to decrease the oxygen demand from the heart. So the name tells you what they do. They inhibit angiotensin converting enzyme. And this is the enzyme that regulates blood pressure. I'll show you what happens on the next slide. So it is a large group of safe and effective drugs. It is the first-line drug for heart failure and hypertension. It has renal protective effects in patients with diabetes. So you want to give these for patients with diabetics. You don't want to give beta blockers or other cardiac drugs if we can, right? We want to give it to those. These ACE inhibitors can still cause renal impairment. So you need to be careful with that. Some of the ACE inhibitors are called prodrugs, and some are not prodrugs. So this is important for you. Let me tell you what a prodrug is. A prodrug has to be metabolized by the liver in order to work. Prodrug must be metabolized. Non-prodrugs work right away. They don't have to be metabolized. They get in there and start working right away. So a couple of the ACE inhibitors are prodrugs, and when I get to them, I'll tell you which ones are prodrugs. But the ones that aren't would be great to use for people with liver failure, right? So when you know it's not a prodrug, it'd be good for liver failure because it doesn't have to be metabolized by the liver. ACE inhibitors cause all of these side effects here: dizziness, orthostatic hypotension, GI distress, cough, headache. They also cause high potassium. So potassium levels need to be monitored with ACE inhibitors. Okay? Side effects not noted on the slide: fatigue, dizziness, headache, mood changes. So think about that. And the hyperkalemia. ACE inhibitors are great. They're first line of choice, but they do produce a very distinctive, dry, non-productive cough that sometimes really bugs people, and they don't want to take it because of that. The cough is too annoying. They want to be switched to something else, and it's their right. We switch them to something else. ACE inhibitors, like I said, are the drug of choice for hypertensive patients with heart failure. Captopril and lisinopril are the ones that are not prodrugs. So this means they can be used if the patient has liver dysfunction. All the other ACE inhibitors are prodrugs. There are some drug interactions, though, with ACE inhibitors. We wouldn't want to give with NSAIDs, so nonsteroidal anti-inflammatory drugs will reduce the effect of ACE inhibitors. So definitely we need to inform our patients of that. So there is a video that I have posted on the RAS system. I've posted it in this week's folder, so go in. There's 2 videos I'd like you to watch. It'll help you maybe understand some of this material. When the blood pressure falls, a protein called renin is released from the kidneys. This produces angiotensin. Angiotensin starts as angiotensin 1, and then it turns into angiotensin 2. And that action and the 2 protein is what causes a rise in blood pressure. Angiotensin 2 is a potent vasoconstrictor, and it causes aldosterone secretion from the adrenal glands. Then aldosterone stimulates sodium and water absorption, and that raises the blood pressure. So it's like a system. And I want you to watch the video and you'll see how it works. And maybe it'll help you understand why these the kidneys impact the blood pressure. So the inhibiting drug, an ACE inhibitor, prevents the conversion and therefore keeps the blood pressure low. There are some renal protective effects of using an ACE inhibitor. It reduces the glomerular filtration pressure. It is definitely the drug of choice for patients with diabetes who have hypertension. ACE inhibitors reduce proteinuria. You don't want diabetic patients to have proteinuria. So when you give them an ACE inhibitor for their hypertension, it helps prevent the progression of their diabetic neuropathy. It's really good for them. But they've got kidney disease to begin with, most likely, and that is what's causing their hypertension. So it's very common to see hypertension linked with your diabetic patients, and the ACE inhibitors hit it at the source and help drop it. Angiotensin II receptors are also referred to as angiotensin II blockers, very similar to the ACE inhibitors. Remember, ACE blocks angiotensin I from converting into the hypertension-creating angiotensin II. The difference between ACE inhibitors and angiotensin II blockers is that the angiotensin II is already created. The blocker just prevents it from attaching to the receptor it needs to attach to in order to increase blood pressure. So when angiotensin II can't attach, the blood pressure doesn't increase, it's lowered. It seems odd that they do the same thing, only a tad different by way of which spot in the pathway that they work, but they do. These meds sometimes are a better choice than an ACE inhibitor because, remember, ACE inhibitor has that dry cough. These don't use that dry cough. So they're just a better choice sometimes. They're used for hypertension, and sometimes they're used with other drugs to treat heart failure. Sometimes they're used with diuretics to treat heart failure. So they deal with the adrenal gland, vascular smooth muscle. The adverse effects are many. There's going to be chest pain, fatigue, low blood sugar, maybe some diarrhea, maybe they'll get a urinary tract infection, anemia, weakness. Much less likely to have that cough than with ACE inhibitors. And the most common one is losartan, Cozar. It's very beneficial for patients, but you have to use it very cautiously with patients with renal disease or liver dysfunction. Okay, so the next category, and notice the ending, ARTAN, that's angiotensin II blockers. Calcium channel blockers. Very nice drugs. Calcium channel blockers. They're used for hypertension and so much more. They're used for angina, which is chest pain, SVT, which is supraventricular tachycardia, really high heart rate, artery spasms. They're used for, which is called Prinzmetal's angina. They're used for AFib, aflutter, which are different irregular heartbeats. They're even used for migraines. They are just used for so much. They're also called calcium antagonists, calcium channel blockers. They end in IPINE, so that's a nice suffix to remember. And the primary uses are hypertension and angina. They block the binding of calcium to its receptors, and it prevents a contraction, so it causes smooth muscle relaxation. This reduces the workload of the heart. It decreases the oxygen demand. Contraindications would be acute MI, hypotension, if somebody has a heart block or an allergy. Lots of adverse effects of these drugs, though. Any heart drug has lots of adverse effects. Here are the adverse effects of calcium channel blockers. They lower your blood pressure, right? So you wouldn't want to give it if the blood pressure is too low. They cause palpitations. They cause tachycardia, bradycardia, nausea. They cause constipation big time, so you have to teach your patients. Now, Here's the list of drugs that I referred to earlier. So here's a list of ACE inhibitors, beta blockers, calcium. They all have their little ending, okay? Captopril, Capitan is very commonly used. It's one of the first, in the first category of ACE inhibitors, just because at the bottom, they're in random order. Captopril is great because it's not metabolized by the liver. Remember, it is not a prodrug. It's got a very short half-life, though, so you have to give it 3 or 4 times a day, which kind of stinks for people who maybe don't remember to take their drugs. Vasodilators. Vasodilators relax smooth muscle. They do peripheral vasodilation. This decreases the blood pressure, so you have to monitor blood pressure with any vasodilator. They are only used to treat hypertension. They can be used with other drugs. There's one called sodium nitroprusside that is reserved for the management of hypertensive emergencies. We don't give nitrates if the BP is low, though, so we have to remember vasodilators only if the BP is high. Lots of adverse effects. Sodium nitroprusside has bradycardia. It decreases the platelet aggregation, which might cause bleeding, rash, hypotension, and all kinds of other cardiac problems. Here's some miscellaneous drugs. Inspra, it's a selective aldosterone blocker, so that RAS system reduces blood pressure by blocking aldosterone and its corresponding receptors in the kidney, heart, blood vessels, and the brain. It's given for hypertension and for some heart failure. Nursing implications. As usual, you're going to monitor for therapeutic and adverse effects. You're going to do your health history. You're going to assess for contraindications, right? You're going to educate the patient about not missing doses. They need to take their doses. They need to check with their doctor. They need to not double up on a dose if they miss a dose. They need to monitor their blood pressure. Get checks regularly. Every time they go to the drugstore, check their blood pressure. If they stop these drugs abruptly, they may get rebound hypertensive crisis, which will lead to a stroke. So it's just really bad. Oral meds should be taken with food so that it absorbs more gradually and is more effective. If we have to give any of these vasopressors in IV form, they have to be on a cardiac monitor, an IV pump has to be used, they have to be monitored. Patients need to still attempt to adjust their the lifestyle things, the modifiable risk factors, right? So they need to watch their diet, their stress, their weight, their alcohol intake. They need to exercise and don't smoke, that kind of thing. They need to change position slowly to avoid orthostatic hypotension. They need to report anything like difficulty breathing, any excess swelling, chest pain, palpitations. And now we're on to chapter 28, diuretics. Diuretics are drugs that accelerate the rate of urine formation, right? So when you pee, you remove sodium and water. And when you get this fluid off, it treats your hypertension because it's like your plumbing isn't full anymore. It decreases. Think of the water balloon. A full water balloon has lots of pressure, but then when it's not full, there's less pressure, so the blood pressure is lower. So we have to know a tad about electrolyte sodium in order to understand diuretics. So here you go. In the nephron of the kidneys, where sodium goes, water will follow. So 60 to 70% of sodium in water returns to the bloodstream by the proximal tubule in the nephron. 20 to 25% is reabsorbed into the bloodstream. And then the rest just goes different places. But if water is not absorbed, it's excreted in the urine. Now here's a kidney, or a nephron site. There are 5 different types of diuretic, and they're listed here. The location in which they work and the functions kind of tell you what they do. So they work in a different location, and you'll see they're numbered here. So like a loop diuretic works in the loop of Henle. So it's just kind of interesting. You don't have to know this for testing purposes, but they're called different things by the location of where they work. So one type of diuretic is carbonic anhydrase inhibitors. They're used for glaucoma, lower intraocular pressure, edema, altitude sickness. They're not used a ton because they can cause hypokalemia. If you take them with a med called digoxin, toxicity may occur. If you take them with corticosteroids, hypokalemia may occur. And then they increase the effect of other drugs, so they're not commonly used very much at all. Carbonic anhydrase inhibitors, what this slide tells you everything you need to know. Loop diuretics are widely used. They're extremely potent. They possess renal, cardiovascular, and metabolic effects. They act directly on the loop of Henle to inhibit chloride and sodium reabsorption. They result in dilation of blood vessels and reduced peripheral vascular resistance. They are used to treat edema. They are used for cardiac failure. They will reduce the blood pressure. So many times they are used as an adjuvant blood pressure medication. But you have to know what somebody's blood pressure is before you give this, because you don't want to give it to somebody who has low blood pressure. When we discuss interactions or contraindications, we need to remember that. Watch the low blood pressure. Contraindications with loop diuretics and drugs called digoxin. The brand name is Lanoxin. It's commonly used in heart failure, so next week you'll learn about this drug. Diuretics and digoxin cause something called digoxin toxicity. Funny colors, blind spots, blurry vision, all kinds of visual disturbances. Confusion, irregular heartbeat, nausea, vomiting, diarrhea, loss of appetite. So digoxin toxicity and diuretics go hand in hand. It's a contraindication putting them together. Lasix is a loop diuretic. That's the brand name, and it is furosemide. Then we have osmotic diuretics. Osmotic diuretics are used, they work mostly in the proximal tubule. They are non-absorbable, and they produce an osmotic effect. So they pull water into the renal tubules from the surrounding tissue, and it produces rapid diuresis. They are used to treat patients in early stages of acute renal failure. They are used sometimes if somebody's got some toxicity. They can promote excretion of the toxic substances. They can even reduce intracranial pressure. So osmotic diuretics pull water in. They are the treatment of choice of cerebral edema. So knowing what they treat helps you understand what they do, right? So if they reduce intracranial pressure, cerebral edema, they reduce excessive ocular pressure. Mannitol is the most common osmotic diuretic. It is only given IV. A filter is required. It cannot be exposed to a cold temperature, so you wouldn't put it in the fridge or it'll crystallize, but it's called mannitol. Now we've got potassium-sparing diuretics. And you need that. If you're getting a diuretic's going to pull the potassium out with the fluid that comes. So furosemide, Lasix, loop diuretics, those are going to pull the potassium out. Osmotic diuretics are going to pull potassium out. But potassium-sparing diuretics won't pull so many. So the examples of potassium-sparing, spironolactone and triamterene, prevent potassium from being pumped into the tubules. So it prevents the secretion while it's pulling out the fluid.